Because that is what your seniors are doing. The other subjects will be covered, and if we have time, I am here for about 4-5 minutes, then I will teach you the squint or whatever, the cataract or whatever it is, right? So, as soon as I begin with the squint, the first question is, what is it? That was the very first question that we have to answer. What is the squint? I will ask two students to answer that question before I answer it. Raise your hands. Yes. You want to say something? All of you have seen a squint, I am sure. How many of you have never seen a squinting person? So all of you have seen, right? Just define in your own way what you want. Asymmetric position of conjunctiva. Okay. Good attempt. Anyone more attempt? Yes?
Ma'am, abnormal alignment of eyeball.
Abnormal alignment of eyeball. Both the answers are partially correct, but they are not completely correct. Because whenever we talk of a definition, definition means that it is complete in its own way. You can neither add nor subtract. So a squint is that condition where the two eyeballs fail to focus at a common object of regard simultaneously. Right? So, if my right eye is looking at Dr. Bhavesh, my left eye is looking at that girl. So, they are not focusing at a common object at the same time. It may be other ways. My right eye is looking at Dr. Bhavesh and my left eye is looking at that boy. That is also squint. So, whenever the eyes are unable to focus at a common object simultaneously, this condition is called squint. This may be present all the time. This may be present sometime. This may be present only for any particular gaze. It is present only in this gaze and not in any other gaze. So, whenever there is a failure to focus at a common object of regard, that condition is called squint. Right? So, we have these two eyes. Don't forget, don't mind the asymmetry. I think बहुत बड़ी asymmetry हो गई है. You have these two eyes who are focusing at a common object. Let us see this. Right? So the image of this object, the rays from this object are falling on this fovea here, and the image from this object are falling on this fovea here. This is called a normal alignment of the eyes. Like when you said, madam, improper alignment or wrong alignment of the eyeballs, the immediately next question is, what is proper alignment? Right? So the proper alignment is that both the eyes work together and they focus at a common object simultaneously. That common object may be straight, that common object may be to the right, to the left, near, down, up, near or distance, wherever. But both the eyes are focusing at the same time. A failure to do so is called a squint, right? And now, if one of the eyes is convergent in relation to the fixing eye, that is called convergent squint. If it is deviated outside, it is called a divergent squint. It may also be facing up or down. And as I always tell my students, the MBBS students, that we are very kind to you. We do not bother you with vertical or cyclic squints, except that you should know the terms. So, as far as our detailed discussions in brief will continue, they will be for horizontal distance. Right? So, any of the eyes may be up in relation to the other eye, that is called a hyperdeviation. It may be down, that is called a hypodeviation. Right? It may be rotated like this or like this. Right? So when the 12 o'clock limbus is rotated towards the nose, nasally, that is called encyclodeviation. And when the 12 o'clock limbus is deviated away from the nose, that is called excyclodeviation. So deviation from normal alignment is called normal alignment of focusing at a common object at the same time is called squint. This deviation may be inwards when we call it a convergent deviation. We also call it a isodeviation. It may be outside when we call it a divergent squint or an exodeviation. It may be up, hyperdeviation, down, hypodeviation, inward rotation of the 12 o'clock limbus, encyclodeviation, inward and outward rotation of the 12 o'clock limbus, excyclodeviation. So this is as far as the direction of squint is concerned, right? Now, what happens when someone is squinting? What's the problem? As far as the patient is concerned, the first problem is cosmetical balance. Right? That is what bothers the patient the most, that is a cosmetic deviation. Right? What bothers us more is that the eye which is deviated, that gradually loses the habit of working and becomes a lazy eye. Right? Also, gradually both the eyes lose the habit of working together. Right? What are the advantages of both the eyes working together? So, there is binocular single vision. As I said, both the eyes see a common object. The brain fuses them as one. That is binocular single vision. If I close my left eye, I also see you as one. If I close my right eye, I also see you as one. When I open my both eyes, then also I see you as one. That is simultaneous macular perception. Right? The second step to this is binocular fusion. So, there is simultaneous macular perception, which is also similar to binocular single vision. Right? Both eyes are seeing one. Right? Then they are fusing one. Right? तभी तो fusion होता है. And once you fuse, the third step is stereopsis. Stereopsis. So these are the three stages of, or three grades of binocular functions. Grade 1 is simultaneous macular perception and binocular single vision. Both the macula see together and they fuse as one. Right? That is grade 1. Clear? Grade 2 is fusion. Fusion is that fusion has some range. Fusion is I see you as one. But while I am seeing you as one, the desk in front also I am seeing as one. I am not seeing two. The desk behind also I am seeing as one. So there is a range of fusion. And with this range of fusion, the third stage is stereopsis. नहीं समझ में आया? क्या नहीं समझ में आया? Stereopsis. है? क्या नहीं समझ में आया? Your question has to be clear. binocular fusion नहीं समझ में आया, okay? See, my right eye is looking at you, right? My left eye is looking at you. Both these visual impulses are going via the optic nerve, optic chiasma into the cortexes of the other side also, and also some after decussation on the same side also, right? So and now these I am seeing one, whatever is your name, what is your name?
Anju.
Anshu.
Anju.
Achal. One image here, one image here, but I am not seeing two you, I am seeing one you. So that is fusion. Fusion is at the cortical level, it is not at the eye level. So these images of this that have gone, they will go via the optic nerve, optic chiasma, right? Into the cortex of this side, into the cortex of this side, right? So one anchal is here and one anchal is here. But my brain is not seeing two anchals. My brain is seeing one anchal here. Right? That is fusion. Right? And once I develop fusion, then only I can develop stereopsis. Stereopsis, you all know depth perception. Depth perception means when I am seeing, even if I am seeing this pen, I know that this one is closer to me, this is away from me. Right? When I am seeing this whole row of boys, I am seeing you are ahead of me, you are behind me, you are behind me. So stereopsis is the function, a higher function of fusion. Right? I know you all can come to me with n number of questions, I know that. And I can also start asking you n number of questions, but we don't want to confuse the subject, right? There are many monoocular clues for depth perception also. But by and large, stereopsis is a binocular, right? So when there is a squint, there is no SMP, no BSV, no fusion, and no stereopsis. And there is a age till which it can develop. Just like a child learns to walk, crawl by 6 to 8 months, walk by 1 year, 1.5 years, talk by 1.5 to 2 years. Same way, for development of fusion and stereopsis, the age that has been defined is maximum up to 3 years, and thereafter slowly up to 6 years. Right? So I said, if there is a squint for the patient, the problem is of cosmetics, by and large. For us, the problem is of the eye becoming lazy and the patient losing the potential for binocular vision. Right? So, the squint may result from many factors, right? One is a paralytic squint. That is easy for you to understand. Paralytic squint, the easiest muscle to understand is the lateral rectus. Left lateral rectus muscle gets paralyzed because of trauma, because of infection, because of some space occupying lesion, because of some parasitic cyst, because of anything. The right lateral rectus becomes weak or stops working, the right eye goes in. Simplest example of a paralytic squint, right? It can be in relation to one or more muscles. We all know that these muscles are supplied by nerves. So, for example, if it is a third nerve which is involved, you will have multiple extraocular muscles which are paralyzed. If it is the fourth nerve is involved, you will have which muscle? Superior oblique, which is paralyzed. If it is the sixth nerve which is involved, you will have lateral rectus. It may be unilateral or bilateral, and as has been taught to you, you all are pathology experts, physiology experts, that the lesion may be inflammatory, neoplastic, parasitic, space occupying, benign, malignant, whatever the nature of traumatic nature of lesion, but paralytic squint is that which results from paralysis of one or more of the extraocular muscles, right? The second big group is non-paralytic. I put paralytic first because it is easier for you to conceptualize, right? The non-paralytic squint occurs because of some incoordination between the neuromuscular pathways. There is not any element of paralysis of this muscle or that muscle or this nerve. It is a incoordination. The incoordination may be of a at a central level, central nervous system. The incoordination may be because of something like what I was telling you in the morning. There is mismatch between accommodation and convergence, right? So maybe because of accommodative problems, that is. And thirdly, the incoordination may be what we call as sensory. Sensory means what? That the input from any one of the eyes is not there. Maybe because of a corneal opacity, maybe because of a congenital cataract, maybe because of some developmental defect, the level of the macula or choroid, and there is the sensory input from one of the eyes is weaker. So when the sensory input from one of the eyes is weaker, it does not correspond and work in simultaneously with the other eye, and it gradually deviates, it gradually takes up its position of rest. Right? So whenever there is a sensory input weak from any of the eyes, there will be a squint. Right? Clear? And the third type of a squint is a restrictive squint. Restrictive squint basically means that you know what is restriction and what is paralysis. Yes or no? My right lateral rectus is not able to pull my eye out because it is weak, it is paralyzed. That is paralytic squint. My right lateral rectus is not able to pull my eye out because something is holding the eye on this side. That is restriction. Right? That something may be a fibrous tissue, it may be a fibrotic muscle, right? It may be a long-standing inflammatory lesion which has resulted in lot of adhesions. So that is a restrictive squint, which I usually do not teach to the undergraduates. Right? So, for the time being, we'll forget about that, except only as far as the types of squint is concerned. You can put it there. There are 3 types of squints: paralytic, non-paralytic, and restrictive. Finally, we will teach you only the other 2 not discriminate. Right? The paralytic squint is also called incomitant squint. And the non-paralytic squint is also called concomitant. Right? As I was telling you in the morning, when the patient comes to me, he doesn't tell me, sir, I have got cataract, or sir, I have got macular degeneration. He tells me I have got poor vision. Here, when the patient comes to you, or the patient's parents come to you, they will tell you that he has got squint. Right? Now, it is for you as a doctor to at least identify what type of squint it is and what has to be done for it. Right? For identification, again, you will begin from A, that is history. Right? And in history, you want to know the duration of squint, the time of onset of squint, the mode of onset of squint, right? And these things may be able to tell you something. If the patient is able to tell you a exact date of onset, it has occurred from yesterday, it is there for last 1 week, right? Then it is something that, some event that has occurred. If the patient is unable to tell you exact duration or an exact age of onset, बचपने से है, जब देखें रहे तभी से है, तो that means that you never know since when it was. Maybe it was since early childhood and the patient started getting bothered about it later. So whenever you are not able to elicit a precise date and age of onset, it is usually a non-paralytic or an incomitant squint. Right? Whenever you are able to elicit a precise date or age of onset, or at times a mode of onset, चोट लग गई थी, बुखार हो गया था, you know, there was some redness or inflammation in the eye before this happened, there was headache, then you know that this is probably paralytic. Right? In the history, you also want to find out the progression. Like, okay, you saw it 5 years back. What has happened to it in these 5 years? It is improving, it is worsening, it is the same. Right? You also want to find out in history whether this squint is there all the time or it is only sometimes. The parents may tell you कभी थक जाता है तब होता है, otherwise नहीं होता. So obviously it is bothering the parents less and it will bother us also less. If it is present all the time, these consequences will be more severe there, right? So we want to find out what is the intermittency and duration of intermittency of this. Clear? In history, mode of onset I told you, then you take whether there is presence of diplopia or not. Diplopia is presence of double vision. And double vision is or since very early age, the eyes are already adjusted to that variation. Right? So the patient does not perceive diplopia. उसको शुरू से वही आदत पड़ गई है. But the eyes which are used, like yours and mine, we are used to seeing straight, we are used to having a binocular single vision, and something happens today and one of the eye deviates, then I immediately get disturbed by diplopia. And double vision can be a very troublesome feature, particularly when you are driving on the road, you are going up and down the stairs. It is very troublesome. So, history of diplopia we take, and if we get history of diplopia, that is usually a feature of that. I am note that I am saying usually. Congenital paralytic squint will not be associated with history of diplopia. Right? Same way, a late onset concomitant squint may sometimes give you history of diplopia. Right? In the history I told you, you take the history of age of onset and duration of squint. Apart from telling you the severity of squint and the severity of the consequences, it will also give you a idea of what is the likely prognosis of this patient in terms of gain in vision and gain in binocular vision. For example, a child who is having a squint since the age of 6 months or 1 year and who comes to you at the age of 13 years, the probability for developing a good binocular vision is very low. Same way, same child, he comes to you at the age of 2 years, the probability for restoring binocular vision is very high. A child who comes to you with a squint at the age of 15 years, which started at the age of 13 years. This child has already developed binocular functions. So they have only been disrupted by this squint and you will be able to restore. So a deviation which has started before the age of 3 years and has come to you after the age of 6 years has poor prognosis in terms of restoring vision and binocular functions as compared to a late onset squint or an early onset squint present in early. Right? Now, examination of a squint patient is the slightly tricky part. And very carefully I am going to avoid the tricky parts to begin with, at least in this lecture. Patient comes to you presenting with a squint. Like in the morning, a patient came to you presenting with diminution of vision. And the first thing that we did was confirm that his vision is low or not low. Same way, the patient has come to you complaining with a squint. You want to see whether he actually has a squint or he doesn't have a squint. Right? So, one is that obviously, you all have seen a squint, the patient is sitting in front of you, you have done nothing, he is sitting like this. It is obvious that it is a squint. Sometimes when it is not obvious, then you have to test. And very, very simple test, you take a torch, show it to the patient from a comfortable distance of near vision and ask him to look at the torch. If the patient is looking at the torch, the minified image of that torch will form on the cornea as a shining dot, what we call as the corneal reflex, and it would be located in the center of the pupil. So, what do we call this test? The right eye is looking at the torch, the reflex will fall. Right? The left eye at that same time is not looking at the torch. It is looking in this direction. So the reflex will form laterally. Right? So let us say here. So what does this diagram tell us? That this patient is having a left convergent squint. Right? Clear? It could have been reverse also. Maybe that the left eye was straight and the right eye was squinting. And these terms that I told you, they are only about the direction of the squint. They are not about the nature of the squint. Any of these squints, paralytic, non-paralytic, restrictive, can be in any of the directions. Right? So, we are at this time heading in this direction, in one of these two directions. Here or here. Right? So, we have a left convergent squint. Now, I want to see whether this patient can actually see with the left eye also or not. Right? So how can I force him to see with the left eye? Occlude the right eye. Occlude the right eye and continue the command. Look at my torch. If the patient can see with the left eye, he will see with the left eye. So what will happen in this? This eye will show an outward movement. And the reflex will now become center. Right? Right? And while the left eye was moving out, the right eye will move in. Which is taking place under cover, and I have not been able to see. Unless you have a cover, we get translucent occluders also. In the translucent occluder, the patient cannot see outside but you can have a look at his torch, at his eye. Right? So if you have a translucent occluder, you will see this movement. If you have your hand or palm, then you will not see that movement, and that is why I am drawing this with dotted line. And while this has happened, the right eye has come here. And it is under cover, so reflex you cannot see. Clear? But just this much tells you that the patient can fix and see with the left eye. Right? If he doesn't do that, if he instead, you cover the right eye and the left eye, he sometimes takes there, sometimes he does this, sometimes he is kind of showing wandering movements, then that means that he has very poor vision in the left eye, he is unable to fix with the left eye, and maybe he has a sensory esotropia, maybe he has a lazy or a amblyopic eye, but at this time he cannot see, so my cover test findings will not be very accurate. Right? So anyway, our patient is able to see, and this movement, outward movement that this patient has done with the primarily squinting eye is called the primary deviation. Right? Primary deviation. This movement that took place under cover, which I was not able to see, is called the secondary deviation. But I also want to see that. How I can see that? Remove this cover and cover here. And when I cover this, this eye will move out as much as it had gone. And that will give me an idea whether the secondary deviation is equal to primary deviation or not. Right? So, this eye will either move this much, this eye can see, or if this eye has moved in here, then this this eye will move this much. Right? To come again to become central. You understand? Yes or no? No complaint, please. Is that right? So, this eye will move this much. When this eye is moving this much. So, if the primary deviation and secondary deviation are equal, then if the primary deviation and secondary deviation are equal, then it is probably a non-parallel telescope. If the primary and secondary deviation are unequal, then it is a parallel telescope. In this case, paralysis of what? Paralysis of left lateral rectus specifically. Clear? And of course, your findings will be supporting the history that whatever you have got, history of trauma, history of fever, history of rapid rate of onset, history of diplopia, that will be supported by your finding of secondary deviation being more than primary deviation or secondary deviation being equal to primary deviation. So all these together, you will be able to start thinking in some line or the other. And after you have done a cover test, you will check for ocular movement. Ocular movements, we test in 9 cardinal positions, and these are dextroversion for myself, dextroversion, levoversion, dextro elevation, dextro depression, levo elevation, levo depression, elevation, depression, and primary depression. Right? So we have begun with the primary position here. After that, dextroversion, levoversion, dextro elevation, levo elevation, dextro elevation, dextro depression, levo elevation, levo depression, elevation, and depression. We do these movements first with both eyes open, then with one eye closed. Now, just to clarify on this point, listen to me please. Talking of the same example here, you have right eye which is straight, left eye which is converging, right? And I am now testing the movements. I test in this case, I find them full. I test in this case, I find that the left eye is not moving to its full extent. And I do it in all other cases, and I have similar findings that the left eye is not moving to its full extent, right? Now, just by this observation, you should not conclude that there is a left eye paralysis. Why? Because if the left eye is having a convergent squint and it is maintaining a convergent squint here, it will give you a false impression that there is limitation of movement. So whenever you get this finding, which in matching with the squint in primary position, you find that there is limitation of left eye in abduction or whichever eye, you close the other eye and now ask him, look at my torch. And if the patient can move, it means that this limitation was a false appearance because of a squint only. Right? So you test the movements with both eyes open and one eye closed, and then you conclude about limitation. Otherwise, you will have a wrong interpretation that there is a left lateral rectus palsy, whereas there is no left lateral. position, looking straight. This eye is straight, this eye is convergent. So this eye is relatively convergent. So it is maintaining that relative convergence here also. It is not moving. It is not moving not because it cannot move, but because this eye is working and this eye is used to not working, so it is not working. When you close this eye, this will move. You understand? Now, if I was you, I would say that why do you test movements with both eyes open? But I am not going to answer that. As you grow up, you will find the answer to that. And if you don't find, well and good. If you become an ophthalmologist, then you will find. Right? So we do a good cover test, we test for ocular motility, and we conclude whichever of these squints we have. Right? Clear? Now, the issue is of treatment also. So we have come to a diagnosis that this is a concomitant squint, non-paralytic squint, and this is a paralytic or incomitant squint. Right? Now, if it is a concomitant squint, I have certain questions to answer. If it is a paralytic squint, I have different questions to answer. Right? Like, if it is a non-paralytic or a concomitant squint, then I want to know what is the refractive status. What is the status of refractive error of this eye? Is this a squint because of that? Clear? What is the visual status of the two eyes? Is the left eye amblyopic or is it not? If it is amblyopic, what is the depth of amblyopia? Right? So if I conclude that this is a non-paralytic squint, that means it is a concomitant squint, then my natural questions are, what is the refractive status of this patient? What is the visual status of this patient? What is the depth of amblyopia if it is there? Right? On the other hand, if it is a paralytic squint, then my questions are, what is the nature of this paralysis? That means whether it is myositis, whether it is neuritis, whether it is an orbital space occupying lesion, whether it is an intracranial space occupying lesion, whether it is a hemorrhage in the brain or in the orbit, or it is a parasitic cyst. So my question is, what is the nature of the lesion that has caused this problem? Right? And my next question is, what is the natural progress of this disease? Suppose it is a idiopathic inflammatory neuritis. Then it is likely to resolve over a period of 3 to 6 months. Right? Suppose the patient has come to me with a history of, let us say, 1 month duration. Then I should be able to retrieve from the history that this deviation, has it been increasing or has it been decreasing? Has the diplopia been increasing or decreasing? So my next question is, what is the natural progress of this disease? Right? The third question is the underlying cause treatable? Right? So the management also of the two types of squints is different. Why do we call a non-paralytic squint concomitant squint? We call it concomitant because in a usual case, the deviation does not change. If the patient is fixing with the right eye, here, it is having this much of deviation. When he is fixing with the left eye, also it is having this much of same amount of deviation. Whereas a paralytic squint, when the patient is fixing with the right eye, he is having this much of deviation. squint, the deviation changes from eye to eye. It also changes from gaze to gaze. If there is a left lateral rectus palsy, the maximum squint will be in the left gaze and minimum or no squint will be in the right gaze. That is why it is called incomitant squint. It is not comitant, it keeps changing. And non-paralytic squint is called concomitant squint because it does not change from eye to eye and from gaze to gaze. Right? So, once your answer is this, it is these questions that you have to answer. Right? Right? What is the refractive status? What is the accommodative status? What is the visual status? Whether there is amblyopia or not. If your answer is this, then the questions that you have to answer I have just now told you. Right? And depending upon the diagnosis, the treatment of both the conditions is different. So, the treatment for a concomitant or a non-paralytic squint the basic principles I am telling you. I am telling you the basic principles. The first aim is to restore vision. If it is poor, restore vision. How can you restore vision? Give corrective glasses. Ensure use of the weaker eye by giving part-time or full-time occlusion to the sound eye. Right? So, restore vision by refractive correction. Enforce use of the sound eye. Of the weak eye, sorry. Right? Clear? The second aim, sometimes after a proper refractive correction, if that was the cause of a squint, the squint may tend to disappear. Right? Sometimes it may not. If that was not the cause, or if it was just the partial the cause, the squint will still remain. So you have to do a refractive correction. Try to normalize the vision if you can. After you have done that, you try to strengthen the binocular functions. As I have told you that this is all what we are worried about. Right? So you can give him fusional exercises. Now this is where your judgment comes, whether you want to give fusion exercises before or after the realignment of the visual axis. So if after all this your axes are still not aligned, you have to realign them surgically. And after you have realigned the visual axes, you have been able to restore vision and fusion, the chances are that the visual axes will remain aligned. Right? If you have been able to surgically realign the visual axes, but there is a poor vision or there is some problem in the fixation, then you will have a realigned eyes but not very stable. Right? So for that, maybe sometimes you may realign and you may have a residual small deviation. So that can be corrected with the help of prisms. Right? conveyed in a very short way. But the message that I want to give you is that very often I get patients referred to me from ophthalmologists, from non-ophthalmologists, from physicians at the age of 15 years, 16 years, whereas they have had squints in 6 months or 1 year of age. And they have been advised by people कि बच्चा है बड़ा हो जाएगा तो ठीक हो जाएगा। तो बच्चा है बड़ा हो जाएगा तो आई का अलाइनमेंट ठीक हो जाएगा, पर जो विजुअल लॉस हुआ है, जो फ्यूजनल लॉस हुआ है, वो ठीक नहीं होगा। So it is your business, whenever you are outside this institute, wherever you are working, if it is a childhood squint, it has to be treated in childhood. If there is a probability that the child will grow out of it, that is for the expert to decide. At least the basic refraction and refractive correction and visual correction has to be done. As I told you, it is a long story conveyed in a very short way and in a precise way so that you don't get confused. So I have tried to remain very, with a lot of effort, very brief. Right? If there is a paralytic squint on the other hand, what you have to do? If it is a paralytic squint on the other hand, what you have to do? क्या हुआ? क्या करेंगे आप? What will you do? What will you do? Your name is? Shubham.
At first we should try to find the cause.
वो तो पता कर लिया ना, वो तो सब हिस्ट्री एग्जामिनेशन सब हो गया. So either the cause is treatable or it is not treatable. Either the disease is naturally regressive or it is naturally progressive. ये सब तो पता कर लिया. अब क्या करेंगे?
I mean, we have to do for the visual alignment, and we have to shift our focus to the muscle of the contralateral side and then reduce its power so that visual alignment is proper.
I have deliberately refrained myself from talking about which muscle we will operate. But anyway, I am not going to that. The first thing is, I will try to find out the underlying cause and treat it if it is treatable. Right? If the underlying cause is a hematoma, I will treat it. If the underlying cause is an inflammatory pathology, I will treat it. If the underlying cause is a thyroid ophthalmopathy thing, I will treat it. Right? If it is an intracranial space occupying lesion, if it can be treated, I will treat it. If it is tuberculoma, I will treat it. Right? If it is a parasitic cyst, I will treat it. So I will, if it is a treatable cause, I will treat it. That is first thing. The second thing is, I will wait and watch for the natural progression or regression of the disease to finish. That means, I will wait and watch till the ocular misalignment either becomes okay or becomes stable. Right? So first thing, I will treat the underlying cause if it is treatable. Second thing, I will wait and watch for the natural progression or regression of the disease process to complete. Right? How will I know that the natural course has now become okay? At least for 3 consecutive sittings, the ocular alignment and the patient's symptoms will be stable. Right? Right? During this period of wait and watch, I have to give the patient symptomatic relief. What is the biggest symptom of the patient? Double vision. The patient is troubled by double vision. While he is crossing the road, he may meet with an accident. While he is going down the steps, he might fall. Right? He might trip anywhere in an unknown surrounding. So, to relieve him of his symptoms, I will advise him to do alternate occlusion, at least in the places where he feels confused. He may not use it all the time, but at least when he is riding a bicycle or a motorcycle, or he is crossing a road, or he is running down or up the stairs, he should occlude one eye. Not any eye. One eye today, one eye tomorrow. One eye today, one eye tomorrow. So that during this period of wait and watch, both the eyes are being used. So during the period of wait and watch, you will give him alternate occlusion. Right? You will give him supportive therapy because it is a problem of the muscle and the nerve. So you will give him supportive therapy in terms of anti-inflammatory drugs, in terms of neurotropic drugs like B1, B6, B12, so that the recovery is facilitated. Right? You will do this till the deviation disappears or becomes stable. Only then you will do a surgical repair. Clear? So, treat the underlying disease. Right? Wait for stability. Relieve symptoms till then. Alternate occlusion के और क्या फायदे होते हैं? हाँ? लेजी आई तो तब डेवलप होगी जब वो 3 साल का बच्चा होगा। अगर 30 साल का मरीज है तो थोड़ी लेजी आई डेवलप होगी। लेजी आई डेवलप्स इन ए आई विद ए immature visual system. Right? Alternate occlusion का दूसरा फायदा ये है कि suppose I have left lateral rectus palsy, my this eye has become like this and this eye is like this. Right? Naturally, I am more comfortable with seeing with this eye. I will all the time be seeing with this eye. This eye is all the time like this. I will develop secondary contractures here. Right? So, alternate occlusion का दूसरा फायदा ये है कि secondary muscle contractures prevent. So you see, we have talked of two diseases. They are two different diseases. Concomitant squint is different, paralytic squint is different, etiology is different, treatment plan is different, surgical plan is different. Surgical plan we cannot do today. If we want to do, we will do it in brief some other day if we need. Any questions? No talking amongst yourselves. When a senior faculty member is present, all the talking has to be to the faculty. Any talking amongst yourself can be done outside the classroom, in the hostel. Any questions? No questions. So, when there are no questions, then the conclusions can be only two. What can be the conclusions? All or none phenomenon. Either you have understood everything or you have understood nothing. So, your homework is to read briefly about the surgical plan, because that is one thing that I have not touched, and I have not touched many things in the cover test of a concomitant squint. If I touch them, you will get thoroughly confused. So, for the time being, this much is enough. Right? If we have time, we will talk some other lecture, or as far as you are concerned, this is enough. As far as complicated squints are concerned, confusing squints are concerned, we usually do not order our undergraduate students. Right? Someone tells you that I have got this patient has got a cataract, and then you say that in cataract the pupils are looking whitish, the vision is poor, the pupillary reaction is good, the projection of rays is good. So this patient, so that is not how you think. You first find out the symptoms, then the signs, and then you put two and two together to come to a diagnosis. Clear? So today we will talk about, can you tell me some common symptoms that are there that the patient comes to you, may come to you in ophthalmology clinic? Loss of vision. More common than that? Diminution of vision. Yes. What else? One. Diminution of vision, redness of eyes, watering of eyes, right? Diminution of vision may be in a different way, something like eye strain, difficulty in seeing, clear? Headache. So we will today talk about diminution of vision. Clear? We all know that ophthalmology, the eye is related to the main function of seeing, other than so many other functions that it has. So, a patient who comes to you with diminution of vision, can you think of some causes that may give rise to diminution of vision? Refractive errors. Cataract. Glaucoma.
Excessive corneal thickness.
Excessive
Corneal thickness.
corneal thickness. Okay. Let us put it in a more systematic way. Let us think of the eye structure. Let us try to imagine what the eye is having. Right? So, what is the eye having? The eye has a cornea, right? Clear? Which continues into the sclera. Right? Then there is the iris, the ciliary body, the choroid. Right? आप लोग तो एनाटॉमी के विद्वान हैं. Am I right? And then you have the retina here. We all know that the retina has the primary receptors for the light, right? And then inside this structure, we have the suspensory ligaments and the lens here. Clear? So, this whole component is responsible for transmitting the visual stimulus to where? To the brain. To the brain. Through the optic nerve, the chiasma, the radiations. Right? So, what now once you have these once you know that this whole system is responsible for vision, what can be the problems? Number one, that the rays are not allowed to go inside the eye. Right? The rays are not allowed to go inside the eye. That means the light rays that are falling here are getting obstructed. Where all can they get obstructed? In the media. The media are those structures through which the light is passing. Now these media, so a problem in the media in the form of a media opacity, partial or complete, will give rise to diminution of vision. And this can be, the media is comprises of cornea, aqueous, lens, vitreous. being allowed to focus properly. That means they are being refracted in a improper way. So that is a refractive error, and the causes of refractive error usually may be in the cornea, sometimes in the lens. It is called refractive error, it is not called refractory error. Sometimes I see students calling it refractory error, and even young faculty calling it refractory error. No. Right? Then the third problem may be somewhere here. Some disease of the receptors. Like what? Huh? Yes. Again, I would make a small general statement here. अभी यहाँ पे कोई काला काला जानवर आने लगे अंदर, ओ माय गॉड, तो आप क्या कहेंगे? भालू आ गया, भैंस आ गई, हैं? हिप्पोपोटामस आ गया. What will be your first reaction? शायद कुत्ता आ गया. Why? Because that is the commonest animal roaming in this street here. Same way, when as a clinician you start thinking or even talking of things, your perspective is slightly different. You talk of things which are more common, right? Now, in this reference here, let me say you could talk of macular choroiditis. Congenital absence of cones is not a very common thing. You could talk of macular choroiditis. You could talk of age-related macular degeneration. You could talk of diabetic retinopathy. You could talk of retinal detachment. So these are some of the common things that we see. So, diseases of the receptors. Right? And finally, fourth, lesions of the visual pathways or the cortex. Diminution of vision, your mind immediately thinks इसमें से कुछ हो सकता है. That is the first reaction. अब इसमें से क्या हो सकता है? That is our job to find out, right? So we take the help of history, we take the help of clinical science. Now, in the history, what is it that will tell you, that will give you some clue? First of all, duration. Is it since yesterday? Is it since 10 years? Or is the patient unable to tell you an exact date? Right? So if the patient is telling you some definite date or correlating his visual loss with a certain date or time, that gives you a hint that he probably is having some disease that started on that day. Right? If he is unable to tell you a definite date and time, it means that it is something very chronic, slow and insidious, which has been there all the time. It is just that the patient has got worried about it now. Right? So that gives you a clue. Now, if the patient tells you that I have this, I don't know since when, you would probably think of a refractive error. If the patient says, no, for the last 2 years or 6 months I am having this problem, you would think of something in the media, right? Or in the retina, right? If the patient is also having some neurological symptoms, you would think of the other pathways. So depending upon the time, if we say मेरे को कल तक दिख रहा था, आज से नहीं दिख रहा है, that means there is a sudden visual loss, and sudden visual loss, sudden anything in the body is usually of a vascular nature. It may be an arterial block, it may be a venous block, it may be a hemorrhage, right? If it is a rapid onset, it is probably having some inflammatory pathology or a slow smoldering disease, right? Now, in the history, you will also take history of associated symptoms. Associated symptoms may be of eye strain or pain or any systemic disease that will give you some clue as to what may be the cause. On clinical examination, again we proceed on the same lines. And as undergraduate students, normally when we teach you, we restrict our examination to the anterior segment. Because we are generally not teaching you how to see the fundus, how to see the visual pathways. We can only take the indirect clues. Now, so you start looking for media opacities, and you do it with the help of naked eye examination with the help of torchlight. You may do it if you are better, you are good, more curious, more inquisitive. As I always tell my students that a good clinician is a detective. You have to be curious and curious. So you have to find out how you can see in the given setup. You may use a magnifying glass to see, right? And if you are in a better center, more advanced, you may use the slit lamp. But a naked eye examination with the torchlight is the primary examination, in which you will throw the light obliquely on the patient's eye and you will look for any opacity in the cornea, any haziness in the aqueous, any opacity in the lens. These three things you can see. Vitreous opacity you cannot see, right? And how do you suspect corneal opacity? You can see it is a whitish thing in between the transparent object. How do you see a lenticular opacity? कैसे दिखती है?
Put the light in the pupillary aperture and then see for the normal brownish black color of the lens. If it is intact, then the lens is intact. If the color is different, then we say that there is lenticular opacity.
Yes, so what do you call this? You look for the type of color that is shining from behind the pupil, right? And that is called the pupillary reflex. That is called the pupillary reflex. That the color that you see from behind the pupil is called the pupillary reflex, right? And the normal pupillary reflex is grayish black. The normal pupillary reflex is grayish black. An abnormality in this color may range from grayish black to white, right? And in between there can be various shades of grey. More grey, less white, equal grey, equal white, more white, less grey, and completely white. So the degree of whiteness tells you the degree of lenticular opacity, right? The brownish pupillary reflex that you are talking about, what's your name here? Shubham. The brownish pupillary reflex that you are talking about, that is seen in nuclear cataract. Right? So the normal pupillary reflex is grayish black. Right? The another abnormality in the pupillary reflex can be that it is black, jet black. And that is when the lens is not commonest cause of aphakia is
Cataract surgery.
post-cataract surgery, not congenital absence of lens. Right? So if you find any media opacities, your next question is that media opacity visually hindering or not? Right? For example, if you look at the eye from the anterior side, इस साइड की आई है ये? कौन सी आई है? हैं? राइट लेफ्ट दो ही आंखें होती हैं। हाँ? Why do you say so? कहाँ है medial campus? हाँ? कहाँ है medial campus? पंक्तम तो बनाया नहीं मैंने। क्यों बैठे? See, this is the medial canthus which is more obtuse. The lateral canthus is more acute. The medial canthus lids, they are slightly having this shape here. This is the point where the punctum would be there. Right? So, which eye is it? Left. This is the left eye, and suppose there is a corneal opacity somewhere here. Is it visually disabling? No, it is not. So that would be our next question. We are not going into that question now. But as a clinician, first of all you detect an opacity and then you find out whether the degree of symptoms can be because of this or not. Right? The next cause, as I told you, is refractive error, media opacity, the receptor changes and the visual pathways changes. The receptor changes and the refractive errors, a very quick test for the students is to do, of course you will do a vision, the patient is saying mujhe kam dikhta hai, you will do a vision and on the Snellen's chart, and you do a vision with a pin. If the vision shows significant improvement with a pinhole, it probably is because of some refractive error, right? We are left with here, 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 right? Now, वो तो आप कह देंगे हमें आता नहीं है, मैडम के पास जाओ उन्हें दिखाओ, is that right? Can you have some indirect clue? Pupillary reaction. Pupillary reaction is an indirect clue to what is happening behind. Right? So again I repeat, when you have a patient complaining of poor vision, you take his vision with the pinhole, you look for the media opacity, and then you look for the pupillary reaction before you do anything else. And the pupillary reaction, you all know, that is not pupillary reflex. Pupillary reflex is the color that shines from behind the pupil. Pupillary reaction is the reaction of the pupil to various stimuli. What are the stimuli that can allow the pupil to react? Light. Drug. Okay. Accommodation, yes. Light, accommodation. And so you look for the pupil. If both the pupils are normal in size, reacting normally to light, then the probability there or is less common, right? I'm not talking of the cortex. For a cortex lesion to present with diminution of vision, it has to be a very large lesion and the patient will have other neurological signs also, usually, right? The pupillary reaction, all of you know. All of you know what? What do you all of you know? Hmm? You throw torchlight on the patient's eyes and the pupil constricts immediately. Right? That is a brisk pupillary reaction. You throw torchlight on the patient's eye, the pupil may react sluggishly. Right? You throw torchlight on patient's eye, the pupil may react sluggishly and immediately dilate. That is called ill-sustained. Right? All these sluggish reaction, ill-sustained reaction, they are all present manifestations of a poor pupillary reaction. What is hippus? It is something like to and fro movement of the pupil. That is normal physiological. Right? So, you throw torchlight here, this pupil constricts, that is normal reaction to direct light. Normal reaction to direct light, you have to have some kind of barrier here so that you are not getting a consensual reaction. And normal reaction to direct light usually tells you that this eye, right eye, optic nerve and visual pathways are okay. Right? You throw light here and you see reaction here, that is consensual reaction. Right? So, you throw light here, this pupil reacts briskly, but that pupil doesn't. What does that tell you?
The fibers that are shared between the right optic nerve and left optic nerve are somehow damaged.
They cross somewhere at the optic chiasma. So, normally, if you have a weak consensual reaction here, then there would be a weak direct reaction here too. Right? But I said you have a brisk reaction here and a weak or a no reaction here. That means that there is some problem, not in the visual pathways, but in the pupil here. Right? Clear? So, with the help of the pupillary reactions, you can get an idea of what the things are like. You do the same thing to the left eye. After you have done the test here, you found that this pupil was reacting briskly